Yes, thank you so much for having me today. And before we get started and before I go over some of our goals for today, I just want to recap some of these wonderful presentations that we've had across the board today. So we've talked about nutrition and what matters most to individuals with Alzheimer's disease. We've talked about mobility issues, medication issues. And what I'm hoping with my presentation today that we'll accomplish is really for those of you who are either in professional or personal capacities, providing that hands-on care to a person with Alzheimer's disease or another type of dementia. And the reason I say this is because my personal and professional sort of frame of reference for providing care to persons with dementia is very interwoven. I'm originally, I guess I should say, I'm a social worker by profession, but I got to that profession because when I was growing up in rural southeastern Kentucky, I was about 6.5 or 7 when my grandmother was actually diagnosed with dementia. And what I saw across the journey that she had with that disease, again, I was a very young child, but witnessing this from that very, very early age, I saw her really go from all of these different transitions of care and no one really honoring what mattered most to her, no one really putting her, in that person-centered kind of viewpoint. Again, this was the early 90s, late 80s, early 90s when this was happening. So we weren't really to that point in terms of dementia care, of talking about dementia in this way. And what I saw for my family in particular was this lack of hope. As it relates to dementia care. So a lot of the work that I do professionally now is very much focused on this concept of compassionate care and these very person-centered compassionate care strategies for persons living with dementia. And so I hope today that as I go through these slides, I'm really able to capture some of that idea of compassion and person-centered care that is so needed in the work that we all do. And again, I'm not going to differentiate when I talk about caregivers today, whether you're a professional caregiver, maybe you're supervising professionally caregivers or a program that's dealing with persons with dementia, or you're a person who's just a caregiver. Because I think that, in order to honor that and really understand that, that fabric of care, that quality care that we all want to provide to individuals with dementia, it's important to just, talk about it from this sort of umbrella term. So our goals for today are really to understand what is compassionate care, what's person-centered care, what does that look like? Because again, sometimes that gets lost in the shuffle, especially when a person has some of those challenges related to cognitive decline. And I'm going to share some examples of that from my both professional life and my personal life as I go through this to kind of highlight how that happens even on a small scale. We're going to talk about how to understand and reframe some of what we call those challenging behaviors that we often see in the care of persons with dementia. And then talk about utilizing compassionate caregiving tools. And again, I think that these can be really applied if you're in a professional role as well, even if you're supervising people who provide care to persons with dementia. I think these are all really valuable things to have in your toolkit. And what I've tried to do today when talking about these caregiving tools that are compassionate is really focus on those things that are feasible and realistic for us to do. So that will be the focus of our conversation today. Now, as I talk, if you have any questions that you want to throw in the chat, I'm hoping Gunjan and Kimberly will help me stay on top of that because with my various screens today, I can't see everything. But if you do have a question as we're going through these things, at the end, please also unmute yourself as well so we can have this conversation. I've left hopefully enough time for us to do that. I tend to be a little talkative sometimes. So let's get into it. I think across the board, most of you are probably attending today because you already are sort of either in the throes of dementia care or you're a professional working in a dementia care setting. And you already know that dementia is a very progressive disease. It impacts memory. I think a lot of times when we talk about dementia care, we focus solely on that memory piece. And I hope that if that is something you were doing in your own practice, that today sort of, got rid of those sort of misconceptions because we've talked a lot about things like nutrition, mobility, medication, all these other things that are going on in that person's life that are really important. Um, but the other thing that I want you to understand about dementia that we haven't gotten into in a deep way is that ability to conceptualize and process new information and old information. And the reason I think this is so important in terms of talking about compassionate care is because often what happens for individuals is it really impacts their logic and their reasoning. And so sometimes what happens for us as caregivers is it becomes very difficult to kind of navigate this new world that they are in. And so all of these changes really impact that caregiving experience. And I always like to say if you look at the right hand side of my screen, the caregiving experience can really go from you feeling like you are really on top of things. You're building up all those sort of processes in your own home, those what I call those to-do lists. You're staying on top of them. You're managing those doctor's appointments. You're figuring out how to do outings with your loved one given their condition and where they're at in the stage of the disease. And then sometimes what happens is maybe you have a day where, think about it like from a visual standpoint, the game of Jenga, if you will. We've been playing various games throughout our breaks today. Think about Jenga. One little thing kind of pulls out of place where it shouldn't be, and the whole thing sort of crumbles. And so within that caregiving experience, we really have to sort of figure out what that looks like for us and be compassionate for ourselves as well. And again, I'm saying this even for those of you who are professional caregivers or working in this world from the professional caregiving sort of standpoint as well, because I just think it's so important to realize that when you're living in this dementia world, so to speak, sometimes one little thing can cause a disruption to that routine that can be very challenging. And the other thing that I think is really important when you talk about compassionate care is language. So I'm going to pause here really quickly. And I'm hoping you all can either unmute yourself or put in the chat, what are some of the first things that you think of or things that you hear, either in society or hear people anecdotally say, or maybe you've heard it in a TV show. When you hear dementia, Alzheimer's disease, when you hear those terms, what are the first words that are often said? So we're going to pause for a second. If you can put that in the chat or unmute yourself.
We have forgetful.
Yes. Old person. Okay. Sad, confused, depressed, memory decline, low quality of life, confused, normal with aging, not compatible, grouchy, angry, dying a sad, horrible death, cognitive changes. Okay, not my Kylie, not my parent anymore. Better off if they died, loss of self, competitive, cognitive decline. Yeah, okay.
Some
I'm
of
gonna
these are
stop.
harsh.
I'm gonna stop you all here. Okay. Think about those words. And again, I know that some of you were putting in things because of the prompt that I gave you to think about things that you hear other people say. So it might not even be things that you think necessarily if you've been on this journey with someone, but it might be things that you've heard other people sort of say, or you might have seen it in a TV show. I was actually watching a TV show that I loved the other day. It's a British TV show, and they did a horrible job of talking about dementia with some very horrible ways to describe what was happening to the person. And I think all of the things that when we talk about dementia care, it all hinges on these really negative phrases, right? I heard several of you in the chat or saw several of you in the chat say old age. Some of the other things that I have heard people say as it relates to Alzheimer's disease is things like thief in the night, or it robs the person of their ability to do this, that, or the other. And what I want to say is that when we talk about compassionate care and we really talk about person-centered care, what you're doing is you're sort of removing the person, one, from that narrative, and you're also using these very negative terms. So, as a person who, I enmesh myself in this world every day, I'm working with caregivers. I've been a caregiver, providing care to a loved one with dementia. You hear this constantly. And so that sort of is this, veil that is over everything that you were doing with that individual. And it is so negative. And so I'd like us to reframe a bit as it relates to this. Because when we start talking about dementia and dementia care in this way, we're really removing the person from the narrative, as I mentioned earlier. We really need to remember the vibrant individual who's living with this disease, their personality, their history, and the fact that they do have this ongoing capacity for joy and connection, even despite, what's going on related to their dementia. And so I think it's really important for us to kind of focus in and hone in on that and not remove the person from that narrative when we start talking about dementia care. And that is step one of compassionate care, quite frankly. That's one thing that we can do that can be helpful in terms of this trajectory. And what this sort of narrative does for us who are working in this field is and those of us who are living it as family caregivers, this negative framing can really lead to this feeling of hopelessness, which is really the antithesis of what we're talking about when we talk about compassionate care. We really want to focus in on that hope that we can provide individuals. And I think that, at the end of the day, I always like to say that, that caregiving experience for a person with Alzheimer's disease or another type of dementia can really be seen as that ultimate, glorious burden. And what I mean by that, those seem like sort of, juxtaposition words there to put together, but glorious in that you get that meaningful time with this loved one that you care so much about. And even if you are a person who is paid to take care of someone, at a certain juncture, you care about that person. You want to provide them quality care. So it is, very instrumental that you're having those meaningful moments with that person. But it can also be a burden, right? Anybody who has ever provided care to a person with dementia has probably dealt with those days where our cup is not full, our battery is not recharged, and we have heard the same question repeated 50 times, right? Anybody else been there? You can say yes in the chat or raise your hand. But that can be such a struggle for us, right? But what I want to do is sort of get to the heart of what we're talking about with compassionate care and focusing on this hope and the fact that individuals with dementia can have these very meaningful days. And they can, and we, as those individuals who are providing care to them, can really help and be instrumental in that. The other thing I want to highlight before we get into compassionate care specifically is sort of this idea that a lot of times when we talk about dementia, there's a lot going on, right? Dr. Reese talked about a lot of the different mental health conditions this morning that an individual can have when they're dealing with Alzheimer's disease and another type of dementia. We heard from our speaker earlier about the issues surrounding mobility challenges that a person might deal with. So you've got an individual who's dealing with all of these different things going on at once. And I sort of like to view this as it's a complex puzzle that we're trying to deal with. And for those of you who are 80s kids like myself, I like to akin it to a Rubik's Cube. So we're trying to figure out for that individual what interventions really work. Each individual's unique. The challenges that they are dealing with are very multifaceted. So sometimes we're trying to, figure out the puzzle. What works? How do we get everybody on the same page? And when we start talking about some of the challenging behaviors that persons with Alzheimer's disease and other types of dementias are dealing with, those are very complex. I don't know if I can get just people in the chat to say, yes, you've been a caregiver before, or either professional or um, uh, personally, or raise your hand. That would be helpful just to sort of see. You probably know, if you've been in this situation, what some of those behavioral health challenges are. And I think that that is just one of those things that is just so difficult for us to sort of think through and deal with. And, for most of, okay, I'm seeing a lot of yeses. So either been a professional or a personal caregiver. You might be familiar with a lot of these things that I'm about to talk about on this next slide. In that, when we talk about those behaviors, and part of me hates even labeling it as behavior because it's almost like it's a manifestation of what is going on with the individual because of their dementia, that we see some of these things. But for the purposes of trying to figure out creative interventions, sometimes we have to give them a name, right? And so as an umbrella term, we often use the word behavior. And so things like repetitive acts, these can really be very benign things, such as a person asking the same question over and over again, to them engaging in the same behavior over and over again. So I once worked in a nursing facility, and this we were trying to figure out a couple of different interactive activities to do at this facility, and then COVID hit. And this particular resident had a repetitive behavior that they were engaging in that pre-COVID we didn't really care about because it wasn't hurting anyone and it made her happy. And it was sort of this self-soothing thing for her. But she liked to walk up the hallway. So the facility had like a massive hallway that led to all of the rooms. And so she would walk up and down the hallway for hours at a time, and she would rub her hands up against the wall. Now, before, we didn't really care about that. But then during COVID, when we were trying to cohort individuals and also not spread germs, that became a thing that we sort of had to figure out. And so sometimes with those repetitive behaviors, we really have to monitor them and figure out, okay, when are they becoming a little bit too difficult? And we need to figure out an intervention for them. Other more challenging things that we often see in persons with Alzheimer's disease and other types of dementias include things like hallucinations. Um, Sometimes hallucinations are what I would call, the Casper, the friendly ghost type hallucinations, where they're sort of pleasant. The person has an imaginary friend or somebody that they are talking to, that they see in the room that maybe those caregivers don't necessarily perceive or see anything, but it's soothing for the individual. That typically we tend to not necessarily want to intervene on that because it is soothing for the person. We also sometimes get the flip side of that, where those hallucinations are very scary. I was working in a nursing facility recently, and we had an older adult gentleman living in that facility who had dementia, and he had seen wartime activity. He was a veteran. And I can't remember if it was the Korean War or the Vietnam War, but anyway, regardless, he had seen wartime, and so his hallucinations were very much he was in a battle zone, and so sometimes at night he would barricade himself into his room, push his bed up against the door, and the way the door swung, the staff couldn't necessarily get it open. And he would sort of hide underneath the bed and think that he was, hearing and seeing things that weren't necessarily there. And it was very traumatic for him. And it was also challenging for staff because they couldn't necessarily put eyes on him. The other thing we sometimes see are things like delusional thoughts or delusional thinking. Sometimes this leads individuals to hallucinations or leads people to these repetitive behaviors as well. So individuals not necessarily thinking that where they live now, maybe in their nursing facility or maybe they're living out in the community with a loved one, is their home now. And so they're constantly asking, I want to go home. This is not my home. Um, Sometimes thinking people have stolen things from them because they're remembering items that they used to own, things like that. And then we get into things that are also challenging, like anger, agitation, aggression, individuals not necessarily being able to communicate in the ways in which they once were. And so that becomes a challenge for those individuals who are tasked with providing their care. These are some of the more common ones. The sort of that umbrella of what I would call those behaviors that we often see for with individuals. At the root of this, I would say that often what is happening is that we find that individuals, because of those changes in the brain, because of their inability to necessarily have that reason or logic that we are able to sort of engage with, that often that they're trying to fill in the blanks, right, to the best of their ability. And sometimes that leads them to do these things. For some individuals, the anxiety, so Dr. Reese earlier talked about anxiety and depression that individuals often have co-occurring with dementia diagnosis. That's where we often see these repetitive behaviors. Individuals really trying to self-soothe and really try to do these things that make them feel comfortable. I'm gonna get another example of this from, and not to just use nursing home examples. I have other examples here in a moment, but not to just use nursing home examples. But I had this one resident a year or so ago who there was a water cooler that was out in the common area of their space, and he would every morning get up and he would take out 9 plastic cups and fill them all up with water and line them up next to the water cooler and then walk away. He didn't take a cup of water. He would just do this every morning. And he would get upset when he would come back and those 9 cups were still there. And so it was one of those things where we were trying to figure out, okay, what's going on here? And in talking to his children, adult children, I can't remember if it was his son or his daughter, we found out that the reason that he probably did that is that he was a foreman or a supervisor for a construction company. And so he was probably used to doing this for the workers every day. And so that became a whole thing where we had to sort of process, okay, what does this look like? How do we figure out some other things that he can do? Because no one else wanted the water that he had poured. So again, sometimes we're sort of these detectives, so to speak, trying to deal with all of these different things and figure out, okay, what part of the puzzle are we in right now? Now, I say all of this to say that this can really add to caregiver stress. So if you're out there and you are a caregiver or you're running a caregiver program or you're a person who is professionally providing care to a person with dementia, all of these things, all of these puzzles with all of these different people, especially if you're dealing with some of these very challenging behaviors like hallucinations or a person who's constantly feeling like they're having items stolen from their space, or they're constantly asking to go home, and so you're getting these repetitive behaviors. This really exacerbates our stress, right? Think about that. Let's just sit with that for a moment. We're constantly trying to figure out and stay on top of all of these things. So remember that image I had earlier of like the Jenga puzzle where we're slowly building it up, and then as we pull things out or things start happening as it relates to that person's dementia diagnosis, sort of all falls apart, right? And so, it's very stressful for individuals. And I think we have to sort of understand that and be compassionate for ourselves, but also understand that we can sort of be these, what I call dementia detectives, sometimes to figure out that Rubik's Cube, kind of figure out the puzzle of that individual and lead us to compassionate care. Now, what do I mean when I say the word compassionate care? What I'm really talking about is really thinking about and understanding that that person with dementia, they are really suffering. Whether or not they are able to articulate that to us, um, sometimes it's challenging for them to say, that I don't feel great about this, or I'm scared, or I'm nervous, or I'm anxious. They don't always have the words to tell us that. And so, really thinking about it from that sort of perspective and understanding that it's more than empathy when we start talking about compassion. Empathy is more of a, oh, I feel bad for that person, right? Compassion is really taking that empathy and that you feeling bad for that person and taking it to the next level and saying, not only do I feel bad for this person, but I'm going to walk alongside this person and hold their hand, be on this journey with them, help them figure this out. Because all of that can be so helpful for the person. It's really about thinking, from the context of how do I take these activities of daily living that I need to be engaging in with that individual. Again, whether you're a caregiver who's a professional caregiver or a personal caregiver, there are all these things that we're doing with that person with dementia that we're trying to figure out. And so sometimes what we need to be doing as well is thinking about how do I take that, what I would call that basic nursing care, and really thinking about how do I sort of put that into or conceptualize that as a little bit more of compassionate care. And so, really thinking about it from that standpoint, I think can be really helpful. The other thing I do want to say, because again, I've been here as a caregiver, so I never want to demean those basic activities of daily living that we might be engaging in, things like bathing, dressing, helping that person take their meds, feeding them. Um, that's really important for that person's dignity. And I'm not, again, when I say elevating that, I'm not saying that we need to, not do those things, or I'm not demeaning that. It's really more about how can we reframe some of that, especially when we have some of these challenging behaviors that a person might be dealing with as well on top of all that. Things that I'll use as examples here in a moment are things like even basic nursing care, like showering. How many people, for those of you who have been caregivers, how many of you have had challenges with helping your loved one or a person that you were paid to provide care to take a shower? That's a huge one, right? So we really have to not just think about that as a task, um, because sometimes that really helps, or really makes the situation worse. We need to think about it more from that compassionate standpoint, and how can we really, from a much deeper level, um, understand that person and where they're coming from and why they're responding to a simple task like a shower in that way. Um, and the other thing with compassion that I think is really important for us to sort of conceptualize as well is that sometimes it's at those small moments with that individual that we are providing care to that can be so impactful. Okay. It could be as simple as us spending that extra 5 minutes with them and letting them tell us a story. Sometimes we also need to let go of like what reality is from a compassionate care standpoint, because often individuals might just want to be able to express themselves. And if they're able to use their words and express it, let's just sit and listen and be there with them and not worry that what that story they're telling us is not necessarily real or the truth. And just go with it. So compassion takes, I think, multi layers in terms of this sort of way in which we think about the caregiving experience. And sometimes it's letting go of reality and just sort of being in that world with them in that moment, and helping them sort of understand that we care about them. Because at the end of the day, they're not going to necessarily remember that they had that moment with us. But in the moment, when they are feeling anxious and they're feeling depressed and they're feeling stressed, it's that feeling that they feel cared about that they're going to hold on to, right? So I think that compassion is such an important tool for us to use with persons with Alzheimer's disease and other types of dementias. And let me now pivot a little bit here. So we've talked about, some of the ways in which we've kind of put this anti-compassion lens on dementia care throughout time by the way in which we talk about dementia and why language is really important, why hope is really important, and having sort of that reframe of what dementia looks like is really important. Um, let's talk about some practical things that you can do in terms of that caregiving experience that can be really helpful. So let me give you an example. And I like to call this "What's for Lunch," this story, because this is probably about 12 or 13 years ago, I was a paid caregiver for a individual who was living with um, dementia. I'll call it, for the purposes of being simple, probably mixed dementia. She had at various times been diagnosed with dementia with Lewy bodies, Parkinsonian type dementia. So she had a lot of mobility related issues. And then at another point, Alzheimer's disease. Regardless, at this juncture in working with her, it didn't really matter what type she had, because, and part of me says, this is partly because of the nature of what was going on with her. She wanted to speak to the presentation on mobility earlier, and medication, actually, was on a lot of medications and also having a lot of issues with falls in the home, multiple hospitalizations because of that. But one of her primary behaviors that was so challenging for staff, outside of those two main things, was the fact that from the moment that she woke up to bedtime, about every 15 minutes, she would ask you what was going to be for lunch. It was like she had this internal clock that I cannot explain, and I probably could have measured my watch every 15 minutes by this question. And this was, just to give you some context, a residential community where we had about 6 or 7 people living together. And they, all of them had intellectual disabilities, but she, on top of having an intellectual disability, also had this dementia diagnosis. Again, sort of unsure about what type, and had been diagnosed several times with several different types of dementia. And this sounds like a very benign sort of behavior that she wasn't aggressive, she wasn't agitated, she wasn't having these, scary hallucinations. She was just simply asking what's for lunch over and over again. So you would think, okay, well, staff, you could just figure this out. Um, it was very dominating of staff time because you couldn't just answer her. You could not just say, okay, we're going to have a ham sandwich for lunch, Jean, and she would move on. She wanted to spend that time talking about it, and it took away from whatever the flow was from the house during that day. And so staff got together and we were like, okay, what's going on here? Why is this a thing? And we really had to try and figure out, we tried a number of different things. I call this throwing the proverbial spaghetti up against the wall, because we tried, really engaging her with just talking about what we were having for lunch, what we were having for lunch the rest of the week, what every day was, that sort of thing. None of that worked. I can't remember. We tried taking her out for lunch once. That didn't work. She was still very much, after lunch was over, starting at like 1 or 2 o'clock in the afternoon. She started this repetition all over again. And so we sort of took a step back and said, okay, why is this happening? What's going on? And this really comes from this compassionate standpoint of really thinking through, how do we help individuals in these situations? How do we figure out and become that dementia detective to figure out, okay, what intervention is going to work? Because sometimes throwing this proverbial spaghetti up against the wall is very frustrating, right? So over time, throughout my work, I've developed what I call the why model of compassionate care. And that comes from thinking about the what. Okay, what's going on with this person? What's the behavior? What are all the different things that we know about when this started? Um, why did it start? Do we have any history on that individual? What are their values and preferences? Um, how can we then think about some ways in which we can do interventions with them? And then you, thinking about you as the caregiver. Um, and really, and I'm going to come back to my friend Jean here in just a second, but I want to say that really this is about aligning the values and preferences of the caregivers and the care recipients, because a lot of times what happens in the caregiving experience is what, for those of you who've been caregivers, this is going to resonate with you. You get focused on that to-do list, right? I gotta, give my loved one their meds. I've got to get them to the doctor's appointment. I've got to help them take a bath. I've got to help them, get dressed, all that stuff. And so we sort of forget about maybe that person with dementia is not in that same space anymore. They don't care about that. They care about these things that are part of their life that are more soothing for them, whether that be sort of the repetition piece, lunch in the case of Jean, or that individual who is pacing. They're trying to find out, and do something and move because they're feeling anxious. And when we really align that compassionate care, person-centered care approach to aligning the values and preferences of caregivers and care recipients, it can be so helpful, right? We really want to put them at the center of what we're talking about. And Cindy, I see your comment in the chat about looking at her personhood before disease. Maybe she used to be a chef. So let me get back to Miss Jean. So Miss Jean, prior to living in the residential community that I worked in, she, because she had an intellectual disability, she had lived with her mother most of her life. Now, at this juncture in her life, her mother had passed away. She was in her early 50s. And she had been living, I don't remember, 1 or 2 years at the place where I was working at. And she did have siblings who had taken care of her before, post her mother passing away, but pre her living in our facility. And they were able to, and sitting down and having that conversation with them and better learning about her life story and what really mattered to her and what was important to her, we found out a couple of things that really enlightened us that we were able to sort of translate into an intervention with her. So first of all, she lived with her mother until a couple of years before this. And she and her mother were what I would call ladies who lunch. Okay, they would get dressed up 3 or 4 times a week, and the lunch was sort of their big meal. They didn't really eat out, or they would just snack at nighttime or dinner time. And so she was used to this sort of idea of let's go out for lunch. Let's have this experience. Her mother would often invite friends on these lunch outings. There was a lot of conversation. They would talk about books they were reading or the activities that they were engaging in. Often they would then go get their nails done or go for a walk at the park afterwards. And so for her, lunch was like the best part of the day, right? And in the residential community that we were working in at that time, lunch was not a big event. It was let's, get the sandwich on the plate and whoever's home at the moment, let's, take it. Some people were sitting in front of the TV eating dinner. Some people were going outside. Some people weren't even home for it. Some people were packing their lunch to go. And she really enjoyed this sort of idea of sitting down and having lunch and having a conversation, even if at this juncture she wasn't really able to participate in that way, but even just sitting at the table gave her that sense of joy that was so important for her day. And the other thing that really gets at the heart of this is this behavior started after her mother died. So sit with that. It wasn't just that she wanted the lunch piece. I don't even really think she cared about what we were eating for lunch. It was I miss my mom and this is something we used to do together. And now I don't have this anymore. This routine has been upended. And she didn't have the words at this juncture in her disease progression to tell us that, to explain that to us. So we sort of had to really do some investigative work, really get to the why behind that. So really thinking about the history of her, those things that were important to her, what mattered most to her, really identifying those strategies that met her needs, and really involving her in the process of that piece. And so what we did is, as staff, and we were able to do this because, again, I mentioned earlier, it's not like we were in a nursing facility. There were, 50, 100 people. There were 7 in this house that were receiving care from our organization. And so what we did was we made lunch a little bit more sit down, have a conversation. There's a plan. We involved her in that process. She would call, there were other properties that were part of our program. She would call the other houses and invite them for lunch. She would help staff cook, even though a lot of times it was just her standing in the kitchen while the staff was cooking lunch. She was part of that and would help when she could. Because again, at this juncture, there were things she couldn't do anymore, but she felt like she was participating in that. And that really helped. Now, did we see that she completely stopped asking about what was for lunch? No, she still asked that question. But what we saw was that over time, we weren't getting this, I could no longer measure my watch, what time it was, based on her asking the question, because she wasn't asking it as frequently. So I think this really shows you how the why and understanding that can be helpful. And I have one more example before we open it up for questions I want to share. And I alluded to this earlier, and a couple of you put things about this in the chat. But when I was talking about anger and agitation, I mentioned bathing and reluctance from people that you might be providing care to in terms of that shower time, in terms of that bathing sort of experience. And a lot of times, if I'm being very general, when we talk about anger and agitation for persons with dementia, what we often see is that we have the person with Alzheimer's disease. There's a situation that happens, right? And as a result of that situation, we might see screaming, hitting, them throwing objects, things of that nature. And a lot of times that is their way of communicating to us that they don't really sort of like that situation. So instead of saying, I'm uncomfortable or I don't feel good or this isn't working for me, they don't have those words anymore or that reasoning or that logic anymore. And so that's where we see some of these what get labeled oftentimes as combative or aggressive behaviors. And I want you to just see that this is a form of communication for that individual. And so I think that can be really helpful. And when we talk about showering in particular, I always use this example because I think it's really important for us because a lot of us have dealt with this. So think about the act of showering. For those of you who have ever provided care to a person with dementia who really struggles and refuses to shower, when you need that level of care to take a shower, that's often something we do very privately, right? One, you're getting naked. Two, all of these things that you have to do, it's a multi-step process, which can be confusing for the individual. And so what we often see is that people become very combative or reluctant to do it. A couple of things of note in terms of dementia care that we just need to be aware of is that think about getting into a shower. A lot of times our shower, like the basin or the tub of the shower, is all one color. That from a visual standpoint for the individual, they might often feel like they're about to fall through a hole, right? Because of the visual changes that happen in the brain. So that's a challenge. One, water temperature. uh, for things that might feel soothing to us, the water pelting us, the heat of a hot, from a hot shower, that might all feel great to us, but for them it's overwhelming. I think somebody earlier in one of the presentations talked about sensory overload, and a shower can be sensory overload. You've got water pelting you, it might not feel good. You've got the noise of the water hitting the tub, that can be overwhelming, and our loved ones or persons we're providing care to with dementia, they can't say that this is overwhelming for me always, right? And so that's where we see this anger, this aggression, and it's really important for us to really take that step back and think, okay, how are we going to do this? So we know what it's the shower. It's always happening. How are we going to intervene in this situation? And again, going back to you or us in this situation as the caregivers, what are those things that we're sort of putting on top of that person because we're agitated or we're frustrated or we're really struggling? And, I would say to that, sometimes we're again trying to check that task off our to-do list. So we're rushing. And so we're not taking that moment to sort of slow down and say, okay, here's what we're doing next. A good example of this I'll give you is that um, I was I had an aunt, in addition to my grandmother having dementia, an aunt who had vascular type dementia, and showers were just a whole thing with her. Uh, she would get really confused, disoriented, just very aggressive compared to other times of the caregiving experience. Anytime you brought up the word shower or bath, she could not do either. And what we learned from that is that she had had a fall at some point during, and one of us, me or one of my other aunts who was providing care to her, had been part of that. Like we had watched her fall and helped her, but there was that fear involved as well. So we had to take a step back and think about how can we make this situation more fun for her. And in her case, she really loved music. So what we would do is we would pull up, in our phones or a radio or a CD player. I'm really dating myself without a CD player, but a CD player in the shower and play music for her and like sing along while we were working with her to give her the shower. And that really helped. So sometimes it's just those small things that we can do to sort of, again, elevate that basic nursing care that we are doing to that compassionate care space. Another example I have about showering that might be helpful for some of you who might be working in nursing facilities is that a lot of times in our memory care units or our dementia care units, um, we might have our shower space or our tub space behind a locked door with a code for safety reasons. And I was working in a facility last year and we had a resident who she was so funny. Anytime you would try to talk to her about taking a shower, she'd be like, no, 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 no. And anytime we would say, okay, well, what if we went for a spa day? Because we were trying to make it sound fun and we knew she liked to get her hair blow dried and fixed and all of that and get her nails done. So we were trying to like appeal to those values and preferences that we knew she had. And she'd say, yeah, yeah, yeah. Okay, and then we would say, okay, well, we have to start by taking a shower, right? And here's how we're going to do this. She'd say yes all the way up until we got her to the door to go into the shower. And then she was like, no, 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 I'm not doing this. One day we just happened to think, what if we just didn't have, because what would happen is we would get her to the door and then you'd have to punch in a code and open it to get her into the shower space. And we thought, oh, what if we just have the door open? So we did that. We had a staff stand there and hold the door open. And before we turned the corner for her to go into the shower space, it was already open and we just let her on through. It wasn't actually the shower that was bothering her. It was that concept of going behind this closed door to take a shower with staff that was scary to her. So sometimes, again, it's trial and error, us trying to figure out what are those interventions that work. And last but not least, I'm going to move forward here a little bit quickly because I think that it's really important for us to think about the situation and safety. So sometimes we have to think about those small ways to infuse compassion into our work. And a lot of times when you're, especially when you're dealing with hallucinations, anger, aggression, agitation, all of those things, we really want to find that immediate cause of what's going on, and don't ignore a resident when they go from zero, what I call 0 to 60, or a loved one that you might be working with who might be going from they're fine one moment and an hour later you're seeing excessive anger, aggression, agitation, because that might be a situation where they're in pain. They might have an infection. And so we want to really make sure that we're, in tune to that. If something comes out of, especially with behaviors, if it's not a gradual thing that's happening over time, if it happens just out of the blue, we need to get that checked out. The other thing is, again, I don't think we understand the nonverbal cues that we're often giving those individuals with Alzheimer's disease and other types of dementias. Sometimes our simple frustration that we portray that we're not even aware of, they pick up on. So we might be saying, "Yay, this is great, let's do this," but our face is not saying that, right? So really just finding those ways to sort of be in the moment with that person. And maybe put that, it's okay to be frustrated. I want to validate that because I have been there before. But maybe putting that frustration in the jar and putting the jar on the shelf for a moment can be really helpful. And, decompressing later and venting later can be helpful. The other thing is sometimes we might need to, from a compassionate care standpoint, think about how can we incorporate a relaxing activity on the spot, really finding a way to play soft music if that person likes music, or utilizing essential oils in that moment to help comfort that person, especially if they're really struggling in terms of having anger or aggression.